On. So, welcome to another interesting topic of educative webinar from Vijaya Diagnostic Center. So, today's topic is on dengue fever. It is being presented by Dr. Haroon. He is consultant microbiologist working in Vijaya Diagnostic Center since for last 1 year. He has a vast experience in both private diagnostic center as well as in private hospital. He has completed his MD from Kaktiya Medical College and now I hand over the mic to him to continue the webinar series on dengue.
A very good afternoon to everybody. Today we are going to touch on a topic which is dengue. Monsoon being around the corner, it is a good idea to have an overview of what the season might have in store for us. So starting with what is dengue? Dengue is primarily an infection of the tropical and subtropical regions. Now it can range from a non-specific or asymptomatic febrile illness to a fatal hemorrhagic disease. It is an infection which is caused by a virus and it is spread by an insect vector. It is a mosquito-borne disease. Now, the dengue virus is classified under, it's an RNA virus classified under flaviviruses belonging to the arbovirus group. It has four serotypes from 1 to 4. The cycle involves exclusively humans and mosquitoes with no other host intervening. The infection with one virus will give immunity only to the serotype of the virus which is causing the infection. So, there is no cross immunity to other serotypes. No, the vector for this is the Aedes aegypti mosquito, also called as the tiger mosquito. The habit of the mosquito is generally a domestic day-biting pattern. It prefers to feed on humans only. It breeds in stored or stagnant water. It has a very short flight range, and multiple mosquito bites can happen in the same area or the same household. Predisposing factors for dengue are the unique structure of the virus itself, plus the multiple serotypes it has, and the pathophysiological responses of the host. How a specific person will respond to the infection, giving it the spectrum of causing the asymptomatic illness right to more serious infections like dengue hemorrhagic fever and dengue shock syndrome. Uh, the favorable conditions, which are there, it is provided due to uncontrolled urbanization and population growth, which leads to substandard housing or inadequate water, sewer, and waste management, deterioration of public health infrastructure. Faster travel has also been a cause, ineffective mosquito control in endemic regions, and hyperendemicity, wherein multiple serotypes are prevalent in one area. Now, dengue in India has been there since past previous decades. Severe epidemics were seen in North India, in Delhi, and in Lucknow. All four serotypes have been reported from India, and the virus is prevalent in most of the country except the cooler areas. Now, dengue fever, the clinical features of dengue are it has a short incubation period of 2 to 7 days. There is a sudden onset of fever from 40 to 41 degrees. There might be non-specific constitutional symptoms like body aches. It also causes severe muscle aches, retroorbital pain, hepatomegaly, rash. The case definition for dengue fever as per WHO is acute febrile illness with at least two or more of headache, retroorbital pain, muscle aches, joint pains, rash, hemorrhagic manifestations, leukopenia. For dengue hemorrhagic fever, the criteria for diagnosis would be, along with the dengue fever criteria, the additional features like hemorrhagic tendencies, positive tourniquet test, presence of petechiae, bleeding from other sites. Thrombocytopenia is a marked is a Thrombocytopenia is seen wherein the platelet counts may see a marked fall of less than 1 lakh. There might be evidence of plasma leak because of this, that there will be rise of hematocrit, and there will be pleural effusions, ascites, and hypoproteinemia is also seen. So this is an example of rash as well as petechiae. For dengue shock syndrome, apart from the features of dengue hemorrhagic fever, there will be a rapid weak pulse, there will be a narrow pulse pressure, cold clammy skin, and restlessness. The patient might present with abdominal pain, which might be mistaken for an acute abdominal emergency. Now, in primary infection, the dengue IgM antibody appears in the late acute or convalescent stage. That is, after around 4 to 5 days, the IgM antibody will appear. Then IgG will appear, which will last for several years. In a secondary infection means when a person who had dengue already again gets infected with the same or a different serotype. In secondary infection, high IgG levels are seen from the start of the infection, along with a small rise in IgM levels. There might be cross reactions with other flaviviruses. Now, infection with one serotype does not protect against other serotypes. So there is no cross immunity that was seen in dengue infections. Now, coming to the laboratory diagnosis, the diagnostic methods involve detection of the virus or viral nucleic acid, antigens, or antibodies, or a combination of these techniques. After the onset of fever, the virus can be detected in plasma, serum, circulating blood cells, and other tissues for around 4 to 5 days. During the early stages of the disease, that is from 0 to 5 days, virus isolation, nucleic acid, or antigen detection can be used to diagnose the infection. At the end of acute phase of infection, serology is the method of choice for diagnosis. So here what we can see is the different methods for diagnosis have been outlined. Along with that, the confidence level and accessibility can also be seen. Accessibility for the serological methods is more, which can be found very easily. Now, other methods like virus isolation and genome detection, uh, they give a direct high confidence level along with NS1, but it may not be readily available for faster diagnosis. Now, during the early part of the illness, that is between day 0 to 5, the infection may be diagnosed by viral isolation in cell culture, detection of viral RNA by PCR, and detection of viral antigens, that is the NS1 by ELISA or rapid test. Here we can see the various antibodies as well as the antigen on how on the timeline they appear. So RT-PCR and NS1 detection can be done between 0 to 4 days, and NS1 can be detected maximum up to a period of 8 to 10 days. Now IgM and IgG will start appearing the third to fourth day of infection, and IgM will taper after around 2 to 3 months, and IgG might persist for a very long time. Now, antibody response to infection will depend upon the immune status of the host. In primary infection, a slow increase of IgM antibody is seen, which will be the first immunoglobulin to appear. It will be detectable in around 50% of patients by day 3. after the onset of illness. It will increase to around 80% by day 5 and 89% by day 10. In secondary dengue infection, the antibody titer will rise very rapidly. The dominant immunoglobulin is IgG, which will be detectable at high levels even in the acute phase. That is, from day 0 or 1, IgG will be detectable. So IgG might persist for a very long time, maybe for years together. No, in early convalescent stage, IgM levels are significantly lower in secondary infections than in the primary infection, and it might be undetectable in some cases. To distinguish primary and secondary dengue infections, IgM and IgG ratios are commonly used now rather than the older hemagglutination inhibition test. So to round things off, from the onset of illness to 5 days of fever in the early phase of the disease, virus can be detected in plasma and serum by virus isolation, nucleic acid detection, or more importantly, NS1 antigen detection. From sixth day onwards, IgG and IgM antibodies can be detected. For diagnosis, any one of NS1 antigen and dengue IgM antibody assay is confirmatory for dengue. Certain other additional tests might be required for managing the patient, like complete blood count to keep an eye on the platelet levels as well as the white blood cell count and hematocrit. Liver function tests for in case there is hepatomegaly, serum electrolytes, and ultrasound abdomen, chest X-rays for any effusions or free fluid that might have been collected. Leukopenia, thrombocytopenia, and raised liver enzymes are generally seen in a significant proportion of patients. Thrombocytopenia and hemoconcentration are constant findings in dengue hemorrhagic fever, where platelets might drop even to a level of less than 10,000, which increases the risk for the patients. Now, finally, dengue is one of the most prevalent mosquito-borne viral disease in humans. Immediately after the febrile phase, the disease may progress to more severe but less common forms like dengue hemorrhagic fever. Serological tests are the most widely available methods for diagnosis. Dengue NS1 antigen detection and dengue IgM and IgG detection are the methods which are generally done. More importantly, anti-mosquito measures need to be undertaken to avoiding of collection of stagnant water in and around homes, mosquito nets, long-sleeved clothing, in-house spraying of mosquito repellents, and in the community also. Thank you.
Thank you, Dr. Haroon, for giving this clear picture on laboratory diagnosis of dengue. Now the session is open for questions. Okay. So thank you all for joining the webinar.